Well, welcome everyone. Thank you for taking the time out of your evening, away from family, other leisure activities such as television. I do appreciate you coming and hearing my talk about shoulder pain. I'm Dr. DiPaolo. I'm a shoulder and elbow specialist with Wright State University. I practice orthopedic surgery and specialize in shoulder and elbow surgery. And the majority of my practice is dedicated to shoulder and elbow surgery, which runs the gamut from arthroscopic surgery all the way to open reconstructive surgery and non-operative treatments as well. And I take pride in being able to handle the full spectrum of those types of problems. What we're going to talk about tonight is not the whole spectrum of shoulder problems because that's impossible to cover. But we're going to cover 3 specific examples of treatments in which there's more than one option. And so, in a nutshell, if for some reason you had to leave the talk right away and didn't get to see the whole talk, in a nutshell, the conclusion of my talk is basically going to be that it's all about you. It's all about the individual patient. And by that I mean there's a lot of forces at work now trying to sort of make medicine cookie cutter and make everything a recipe. But ultimately, a lot of what we do in medicine, at least a lot of what I do in shoulder treatment, shoulder and elbow surgery, is not cookie cutter. And by that I mean there's more than one good option for any particular problem, which ultimately I think is confusing on your end because your brother-in-law or your uncle or your cousin might have a quote-unquote shoulder problem. And often you're using them as your best frame of reference for your problem. So if you start to have a shoulder condition and it hurts really bad, you gather information from the people you trust. And people you trust are often your family or people close to you. And you try and gather their story in terms of what it was like for them. And we associate their conditions or their words, their descriptions of their own condition perhaps with your own. You think, well, he's got a rotator cuff tear. I was told I might have one. But what we fail to realize is that there's a huge wide spectrum of any one particular problem, and therefore there's often a huge spectrum for any particular treatment. So again, ultimately, if you get nothing out of this talk, I want you to understand that each treatment has to be dictated towards the individual. Because if you look around the room right now, we're all different. God made us all different. We always have been. Some of you in the room are retired. Some are young. Some are working. Some are left-handed. Some are right-handed. Some play sports. So how can I possibly have the exact same treatment for every single person? So spoiler alert, I'm giving away the conclusion right now. That's going to be the take-home message. So I have no financial disclosures except that I do work with Wright State University. So there's nothing else I'm trying to sell you here. So when I put this together, I began to think, in my own experience with patients, you come to realize that there's a wide spectrum of patients that you deal with. And so there's a group of patients who come into the office and they want you to give them the answer. They have a problem, but they want to give over that decision-making to you. You say, you're the professional. You tell me what to do. This is just way over my head. I trust you. You're going to do what's best for me. And then you've got the other end of the spectrum. And that's the person who goes on the web and is searching out every piece of information and calls 20 different people and is trying to figure out exactly how to run every single part of their care, which can be frustrating. I don't mind those types of patients, to be honest, because I enjoy this process of educating, because I think that's a lot of what I do, and I enjoy that part. But it can be frustrating, I think, on the patient's end, because I've been there myself. I was there as a medical student once with a problem, thinking that I could figure it all out. And in reality, what you need is somebody to help you simplify some of that, because there's a lot of rabbit holes that you can go down and get lost in and really waste a lot of your own time. So most of us, I think, fall somewhere in between, thankfully, and I think it ultimately works out well. But you do have to recognize that we probably do fall on that spectrum. I began to think then that not only do patients fall into two extreme categories, but conditions medical conditions, namely in this case, shoulder conditions, fall on extremes, okay? So I'm an orthopedic surgeon. And what that means is that I treat bone, muscle, joint conditions. And so I deal with some things that are very much emergencies. If somebody gets in a car accident and a bone is popping through their leg, that's an emergency. That's something where I have to go in and fix that and wash it out and make sure everything's sterile and that you operate on that. So that's one extreme. You have to operate on that problem in the vast majority of cases. But then there are types of problems that are not extreme. They don't have to be handled today. They may have happened over a long period of time. Maybe you've had a shoulder twinge that's been bothering you for 3 or 4 years, and it's never really gotten in your way, but all of a sudden it's starting to creep up on you. You're really not sure, should I go see a doctor? I don't know. It's not really impacting my daily life. So there's two extremes in conditions. And again, like everything else, it usually falls somewhere in between. Most of conditions, that is. So that's kind of where things get interesting. Because there is such a gray zone, it's an opportunity for not only tremendous confusion among people, because we want definitive answers. We want to know, well, what do I do? All right? Ultimately, life comes down to, what do I do? And it's that gray zone that prevents the most opportunities, but also sometimes the most confusion that we often need the most help with. So it comes down to decisions. Decisions are hard. The reason why decisions are hard is because sometimes you can have too much information. And decisions are predicated on a lot of different things. Because each of us is complex, we all have different goals, different aspirations, different strengths, different weaknesses, different ways of spending our time, different background health conditions. So while I'm a shoulder surgeon, I have to respect the fact that so-and-so patient may have a much more compromised overall medical condition than a different patient, which may be very healthy. And that's a far different picture, and that is what I want to communicate to you, is that those factors all play into my decision making and my trying to help you make a decision, because ultimately it's going to play into what treatment may work best. So I want to relay a story with you, and it's actually a gentleman. I didn't know he was going to come back and see me today, and I was thinking about him, and he's a gentleman who's a physician, retired physician, who has one of the conditions we're going to speak about today. He has osteoarthritis of his shoulder, and I'll show you a picture of it later, what it looks like. There's actually a few different types, and I'll go over his type later. Anyhow, he's in his later 70s, very active gentleman, retired surgeon, mentally very with it, travels quite a bit, but also physically very active, plays tennis. First time I saw him, I looked at his x-rays. Before seeing him, I looked at his x-rays and thought to myself, oh, this guy needs a shoulder replacement, before seeing him. He came into the office, we sat down, we talked for quite a long period of time, and I asked him, well, what have you been doing for this? This must be bothering you. Oh, yes, it's bothering me very much. Well, how long has it been bothering him? Oh, it's been bothering me many years. And I got into asking him about what his activity level was and what he did. And he was telling me all these things. He does push-ups every day. He plays tennis. And I'm thinking in my mind, oh my goodness, how are you doing all these things with an x-ray that looks like that? And the x-ray I'll show you later looks a lot like this gentleman's x-ray. And he had his mind made up. I briefly showed him the model of the shoulder replacement, and I asked him, is this something you consider? And he said, no way, I don't want to do that. And I said, that's fine. And so we ended up giving him an injection, and that was a few months ago. And it turns out, by luck would have it, he came back today, I gave him another injection. So for him, I'm handling his problem in the way that he wants it, right? So for someone else, I recently did a shoulder replacement on a week ago on a woman who had an x-ray that looked very similar. In fact, probably a better looking x-ray, who was nearly his same exact age. She wanted a shoulder replacement. She was tired of dealing with pain. She's not nearly as active as this gentleman, but she wanted the shoulder replacement. So again, two of the exact same problem, but who wanted two totally different solutions for him. And this gentleman wants to continue getting injections and avoid an operation at all costs. And there's no right answer, right? So the right answer is with him. And we're going to hopefully show that to you. So the goal here is to use 3 examples. I'm going to go through 3 different topics. One is adhesive capsulitis, or better known as frozen shoulder. The second one is rotator cuff tears. And the third is osteoarthritis of the shoulder. So my goal is to go through each of those topics briefly. I'm not going to do a textbook here. In fact, one of my goals is to keep this relatively succinct so that we can open this up to questions while not keeping you here all night. Hopefully answer a fair amount of questions here, because it usually is the case that people get the most out of your own questions and other people's questions. So I encourage you, as I'm talking, feel free to write things down, write down questions you may have. We're going to answer any questions at the end, and then I'll also stay later, because sometimes there's a different level of question where people have a little more private concern. So I've had questions where people will ask something directly and say, well, I have this and I have that. Sometimes if you can speak in generalities, that helps everybody, but if you have something more personal, I'm happy to answer that later, because it can be hard to delve into every specific for each person. So I'm going to use these 3 topics, the frozen shoulder, rotator cuff tear, osteoarthritis, as examples of how there are conditions in which there's more than one good treatment option. I'm going to show you specific examples of where that may be the case, what different options you have, and how ultimately with at least these conditions, and others as well, I'm not running the whole gamut, but with at least these, often the power is in your hands, right? And it's really about the conversation that we have to figure out where you fit and what's best for you. So ultimately, you may get equivalent results depending on the particular treatment. You may or may not. But it's often a matter of trade-offs. And the trade-offs come in what level of risk you're willing to undertake, your time frame for when you have to get better or want to get better, your other risk factors, and certain costs. So, and costs are different from everybody. For instance, comfort. Some people are more comfortable with an idea of a surgery than others, and other people are completely, against the concept. So the first one we're going to talk about is adhesive capsulitis. Adhesive capsulitis is better known as frozen shoulder. I'm going to tell you a little bit about the anatomy of frozen shoulder, the natural history of frozen shoulder, who is at risk for frozen shoulder, what it really is, because I think there's some confusion about what it entails, and then I'm going to delve into why you can treat this in more than one way. So there we go. Good. Okay. So this is an anatomic drawing of a shoulder with a number of layers stripped away. So this is the deepest layer of the shoulder. I don't expect everybody to memorize this, but you can if you want to. I, incidentally, had to memorize all of this and look at it every day. So, but anyhow, what this is the deepest level of the shoulder. It's with all of the muscles stripped away. And what you're seeing is what we call capsule tissue. So all of this is capsule tissue. They're broken down into different ligaments. So there's different separate bands, and all of the people who've studied anatomy and came before me and who I'm indebted to describe these various bands. And for all intents and purposes, they each do different things. Yes. Oh, I'm sorry. Okay. I apologize. Sorry about that. I'll come over here. So anyhow, I'm pointing out that there's, and I'll try and make a point of going back and forth if I can. There's different bands of tissue that make up what we call the capsule. And the best way of understanding the capsule is it's a tough connective tissue. It's very elastic. Gets less elastic with time, but when you're young, it's very elastic. And its main function is it helps hold your shoulder in place. So the shoulder is an interesting joint in the sense that it has probably the biggest range of motion of any joint in the body. And that's a good thing in a lot of ways, but it comes at a price. And that price is stability. So the more motion you give, the less stable against certain motions you may be. So it's susceptible to things like dislocations, because in a joint, think of a joint like the hip, which is a ball and socket like the shoulder, but it's made of more bone. It looks more like a cup, whereas the socket of the shoulder looks more like a saucer. And what we're relying on is this capsule tissue and other constraints that you can't see inside there to help hold that in place, namely at the ends of your range of motion. So you can only go so far because you're being held back. So for instance, I can only rotate out about this far, with my shoulder. This is a motion we call external rotation. The reason for that is there are bands of tissue in the front of the shoulder there and there that keep me from going all the way out. Now, some people are more flexible than others. And again, this gets back to individualizing care. So younger patients, I just was examining my son the other day. I have a 3-year-old son. And he can rotate his shoulder all the way out here. I can't do that unless I move my whole body out that way. So there's pluses to being young and flexible. At some point, I guess I was that flexible, but it's been a long time. So anyhow, that's what capsule tissue is. It's in this capsule tissue that you get a problem with frozen shoulder. So frozen shoulder, we don't totally understand why it happens. There's a number of different varieties. Some of them we do. Okay, I take that back. Some of them we do. There's different categories of frozen shoulder. So there's one type which is called post-traumatic frozen shoulder or secondary frozen shoulder or post-surgical. So there we know, right? So you had a surgery done and you got stiff. Why'd you get stiff? Well, you developed scar tissue in this capsule, so everything tightened down. And we all know what scar tissue is. It's the body's way of healing in light of a wound, right? When that happens, it restricts your range of motion and you get tight. Now we know that there's other reasons that this can happen. There's one we call idiopathic frozen shoulder. It's essentially saying we don't know. So we know we think that there's an immune modulator going on that is somehow affecting the capsule. And what we see often is that this happens in certain people with certain risk factors. So diabetics are at risk. People with thyroid conditions. My apologies to the women in the audience, but unfortunately middle-aged women, we don't totally understand why, but middle-aged women in their later 40s, 50s, for some reason are at greater risk. Those people are at risk, and that type of frozen shoulder just comes up spontaneously. So a typical story will be, hey, I started getting shoulder pain I've had it for about 3 months. Well, how did it happen? I don't know, I just slowly kind of came on and I thought I slept on it weird. It's been getting worse. Well, can you reach up in a cabinet to get a glass? No, I've been having a harder time reaching. It's really, it feels stiff. That's idiopathic frozen shoulder, right? But what we know is that the capsule tissue tightens down, just like for other reasons. It's just that we don't totally understand why. And there's good and bad to either kind, right? The good news about the idiopathic frozen shoulder is it often does go away on its own. I'm going to get to that in just a minute. The bad news is it hurts, and usually you know why it's bad, because it's very, very painful to do a lot of normal everyday activities. Oh, sorry, hit the wrong button here. So we went over the anatomy. So it's this capsule, tough, dense connective tissue inside that's normally elastic, getting tight for different reasons. Either you had a surgery and had a lot of scarring, or that just happened spontaneously. The bottom line, though, is you're tight. And tightness leads to pain and ultimately a decrease in your range of motion and a decrease in your ability to do things. You wouldn't notice it if you couldn't buckle your seatbelt. You wouldn't notice if you couldn't reach up or you couldn't reach behind your back to get in your wallet. And so it comes down to, well, what do we do about it? There's good news and bad news. The good news, especially with an idiopathic frozen shoulder, which most people suffer from when they get a frozen shoulder, is that it often goes away on its own. And this is where the treatment options come in. So it's kind of counterintuitive. And recently some studies have been done, and I think it's quite remarkable actually, that they took a group of patients, a large group of patients, and they put them in 2 different categories. So one group, and they all had this idiopathic frozen shoulder or adhesive capsulitis. One group got a standard treatment of what you would normally think of for a frozen shoulder, physical therapy. If it's tight, we've got to loosen it. So how are you going to do that? Somebody's going to stretch you out. You're going to stretch it out. And you're going to do this over and over and over again, and you're going to get loose, and it's going to get better. Injections. Steroid injections. Corticosteroid, which is an anti-inflammatory. It's basically a powerful anti-inflammatory that you take, you put in a needle, and you stick it right where the pain is, right where that inflammation is in the joint, and makes sense, should get better. So they took half the people, and they gave them this treatment, option 1. Right? So it's a little bit of everything. It was injection. It was maybe an anti-inflammatory pill. It was physical therapy. It was somebody stretching this woman out. It was teaching her how to do the exercise. And then they took a group, same number of people, same exact problem, same symptoms, same pain, and they did this. They did nothing. Absolutely nothing. You know what the fascinating thing about this study was? The fascinating thing was if you waited long enough time, upwards of 9 months to a year, and measured out person to person in the group, on average they did the same. So that's what's fascinating about this particular problem. So it comes down to decisions. If you came to me and you were one of those people on the spectrum who wanted me to make the decision for you, you know what to do, doctor, you tell me what to do. And I said, well, you have a frozen shoulder. The question then becomes, well, what do I do for you? Do I do this? Or do I do this? Do I do nothing? Are you the kind of person who wants to do nothing and wait it out? Or do you want to try these other things? And I can tell you, I've had people in both categories. And I can tell you that we actually have to talk to figure out who you are, figure out which of those types of persons you are to decide on doing that. I'll tell you a story about a patient I had with frozen shoulder. She fit the profile. She was early 50s, later 40s, female, did not have diabetes or any other factor. She came in, and she was in an extraordinary amount of pain with her shoulder. And it's actually a relatively straightforward diagnosis to make. It's really a diagnosis you can only make by putting your hands on someone, by actually doing a physical exam, which unfortunately sometimes is rare in this day and age. You don't need an MRI to make it, by the way. And I'll tell you one of the pitfalls of that in just a second. But anyhow, she came in. She clearly had a frozen shoulder. And we talked it over what we wanted to do. And she was very aggressive with wanting to get better. She had a personality of, she really worked out all the time. She wanted to get better fast. And she's actually, she sticks out in my mind because she got better faster than any other patient I've ever seen with frozen shoulder. And what she did was she did physical therapy. I gave her the exercises to do, and she hit them harder than anyone I ever seen. Now, the cost of that was, at about 2 months, she came back really sore. I was amazed at how much motion she got back, but she was really sore. And I said, well, I think you just overdid it a little bit. You know, you're better. And we wound up giving her an injection to kind of cool it down a little bit, and she was better fast. Most people don't get better that fast. Most people, it takes them a little longer because it goes through a phase which can last the better part of a year, almost 18 months sometimes. So then there's other people who, you know, they don't want to do a lot of therapy, or they have issues. We know that injections can actually raise your blood sugar a little bit in some people, and we've done a study out at the VA about that. So if you're someone who's really borderline with your diabetes, you may want to think about that. But anyhow, it just goes to show that there's more than one way to treat it. The pitfall here that I want to point out, and I want you to take this one home too, is that frozen shoulders is actually a relatively straightforward diagnosis to make, but you have to know what you're looking for. So I deal with shoulders every day, and so I'm always tuned in, waiting for it. Other people aren't so tuned into it, and so the knee-jerk reaction may be shoulder pain, we're going to get you an MRI. And while MRIs often tell what's wrong in your shoulder, there's a problem with them. And the problem with MRIs is sometimes you get a positive finding that really is not related to what you in particular have. In other words, with a frozen shoulder, the stiffness part trumps everything. So if you come in and I do an exam on you, and in reality the exam's simple. The exam is I check your motion, right? So I move your shoulder around, and if your motion in what we call an active plane, so me doing this, powering my shoulder on my own, versus someone else moving it, is essentially the same. In other words, you're really stiff when I'm moving it too, then you've got a frozen shoulder. You've either got that or you've got arthritis. And I can almost stop. And the way I check whether you have arthritis is check an x-ray then. But I can almost stop after that. I don't need to go ordering MRIs. In fact, I just had a patient last week who got referred to me, and he came with an MRI and was told he had a rotator cuff tear, and I was expecting to see, oh, this is a patient who has a rotator cuff tear, he's got rotator cuff symptoms. When I examined him, number one, I looked at his chart and it said he had diabetes. So again, I was automatically thinking, this guy's at risk. And I examined him, and within 30 seconds I knew his problem wasn't a rotator cuff tear. while his MRI showed that he had a rotator cuff tear, it was true, he had one, it was small. While it showed that, the stiffness trumped the rotator cuff tear. So you've got to be careful about these things, because if you're convinced in your mind, well, the MRI told me I had a rotator cuff tear. My doctor, my so-and-so told me I had one. They may be right, but if I go and start treating the rotator cuff tear instead of first treating the stiffness, I could actually make the problem worse. If you go and operate on somebody in the middle of this phase where they're getting really stiff and painful, I can actually make you worse. Because frozen shoulder naturally goes through these phases in which they're more inflamed in the beginning and more stiff, and in which you're more susceptible to becoming even stiffer, and then eventually cooling itself off on its own. What you want to do, or what I want to do as a physician, is to help you get through those phases. I can tell you, I didn't include, I should have, I didn't include one treatment option on here, and that's surgery, because I was specifically gearing it more towards adhesive capsulitis, idiopathic, as opposed to say a post-surgical. But you can do surgery for this. It's very rare, though, and I guess it's better that I didn't put it on, because it's very rare to do that. And I can tell you, in practicing as a shoulder specialist, the few capsule releases I've done have usually been in people who've had surgery already and developed some kind of stiffness. It's very, very rare for me to do surgery on someone who has an idiopathic frozen shoulder, because if I can help you get through that pain phase and the inflammation, it often gets better on its own. It goes away. So it's very rare to have that kind that comes up spontaneously need to actually go on to surgery. So you've got to be careful, because if somebody's telling you that, and I've read cases like this where people have come in, they've seen a doctor, they were told, yes, you have adhesive capsulitis, you need to go to surgery. If they're telling you that right away and they're not doing physical therapy or something else or nothing for an extended period of time, be a little leery. So the next condition number 2 I'm going to cover is rotator cuff tears. This condition is at the same time one of the most interesting from my end, and also most confusing, I think, from your end. And the reason it's both is because there's such a wide spectrum of rotator cuff tears. How many people in the audience have heard of your rotator cuff or heard of rotator cuff tear? Great. That's what I expected. I mean, we're dealing with an educated audience here. Everyone is self-selected as being interested in shoulder pain, and it's probably the most talked about type of condition. You'll hear it mentioned with regard to professional athletes, namely baseball pitchers. But it frankly is one of the most common conditions to afflict the shoulder. And so if you actually had to guess the reason why you had shoulder pain, and you were in your 50s, 60s, 70s, and you guessed arthritis, you'd be wrong most of the time, because rotator cuff tears, rotator cuff conditions, far outnumber arthritis in the shoulder, comparatively speaking, except one kind, and I'll show you that in a bit. But if you have to guess, and somebody asks you why you have shoulder pain, and you're middle-aged to older, guess rotator cuff issues, rotator cuff tears. So the bottom line is there's a wide spectrum of rotator cuff conditions, from pure tendinitis, which is a long word that means inflammation in and around your rotator cuff, to full tears that are completely irreparable. To understand some of this, I'm just going to go over a little of the anatomy. Again, I try to keep things, excuse me, there's whole textbooks written just about rotator cuff issues, conditions. But to make things simple, let's break down the terms. So rotator, to rotate is this, right? To move your shoulder, it's this. So that's telling us that these muscles that make up the rotator cuff have a function of rotating, of moving your shoulder in a circular fashion. The other aspect to the term is cuff. So what's a cuff? Cuff, think of your shirt sleeve, right? I think it's confusing sometimes. A lot of people think it's cup, C-U-P. It's not a cup. But what it is these 4 muscles, there's a large one in the front, there's 2 go around the top, and another large one that goes around the back. Again, it's in the front, and then they go all the way around the back. They really encircle the ball part of the shoulder. So the shoulder's a ball and socket. You can't see the socket, but it's sitting back here. they really encircle this ball part of the ball and socket joint. So think of my sleeve. Now my sleeve, my shirt sleeve, my cuff on my shirt goes 360 degrees around, like a circle. The rotator cuff is different. The rotator cuff only goes 270. So you can see that there's a little bare space back here. And if we go back, you see that that space is actually occupied by this capsule tissue. So it doesn't, your shoulder doesn't totally just fall out. That tissue is there to help hold it in place. But going back to the rotator cuff, you can see that it's absent, right? So it really is only encircling 270 degrees. Well, it turns out that these four muscles are pretty confluent. That is, they blend together. So it's often hard to distinguish between the muscles. I know where they are because I know the landmarks. But for all intents and purposes, they act together. Now, some are more important than others, which, again, leads us to different treatment options. So your rotator cuff tear might be different than her rotator cuff tear. And it leads to a whole lot of confusion because it's one of the most common conditions. Everyone has a relative who's had some kind of surgery or injection or something for a rotator cuff problem. And you're thinking in your mind, well, my cousin had this. Maybe I just need X. Or he had that and he said it was terrible. I definitely don't want that kind of treatment. But you don't know, right? You don't know because it's so complicated that you don't know exactly what your condition may be until you really delve deeper into it. So let's talk about the spectrum first of how this can play out. This is just an example. Oops, sorry. This is just an example of a tear in one of the tendons. It's probably going into two of them, actually, if you look at it. And this is the example here. This is an example of a tear. It's a pretty good picture. What it shows is that the tendon, so a tendon is this white stuff that attaches muscle to bone. Again, it's attaching muscle to bone. It's this white stuff. And the white stuff, like the capsule tissue, is a tough connective tissue. It's different than the capsule, but for all intents and purposes, it helps connect one tissue to the bone. If that tissue connection is broken, then the muscle loses connection to the bone, right? So muscles, what are muscles' jobs? Muscles shorten so that they can move your joints. And they're constantly moving together and coordinating. And if you lose that connection and ultimately lose that muscle function, then how does it translate to you? You lose strength. So you get weaker. So you have difficulty doing this. Turns out that these particular muscles serve certain functions. They help keep the shoulder centered. So that ball part is not just centered in the socket by other bone. In the hip, yeah, it sits there like a cup. But in the shoulder, because it's so shallow, you actually need those muscles to constantly work and hold it in place, help center it on the ball. When it's not centered, you know it. You feel a certain sense of instability. You feel kind of either a clicking or a popping or a sense that something's just not right, or just pure pain. I mean, it can just be painful. The different muscles are responsible for different actions. So some allow your arm to do this, some allow your arm to rotate this way, others do this. And each one's different, and I prioritize decision-making often based on which one is torn, which one isn't torn, how long the tear has been there, how the tear happened. So I'll give you an example. I don't want to, my goal is not to impart to you every single bit of the intricacies of rotator cuff tears. But I'm going to give you an example of some decision-making that we have to make with rotator cuff tears. So there's a big difference between a tear that's what I would call traumatic and one that is chronic. So trauma, what's a trauma? Fall down the stairs, land on your shoulder, boom. One minute you have a great shoulder, no pain. The next minute your shoulder's killing you. And it's possible to actually tear away the muscle from the bone with a trauma, okay? The second category in this group would be a chronic tear. So a chronic tear is one that slowly just happens over time. You never had a fall down the stairs. You never had a car accident. You never had some incident where you went from boom being perfect to the next day all of a sudden pain. Your pain happened slowly over time. You slowly notice that, yeah, reaching up and grabbing objects or lifting things, it just started to hurt in here. It just was painful. You started noticing weakness, and Lo and behold, you went to the doctor, you got an MRI, you did something, and oh, there's a tear there. How did that happen? Well, it turns out that as we age, our rotator cuff tendons, along with a lot of our tissues, unfortunately, become less elastic, and they often can tear. They can just tear for no good reason. And a study was done a long time ago, actually by one of the former chairmen of the institution where I trained at Thomas Jefferson University. And they did a study on people over the age of 65. And it was a study which I don't know if you can do it today, but literally he found people who were on their deathbed and he interviewed them, and then he asked if they donate their shoulders after they had died. And so he had a whole group of people, and he found out had they ever had shoulder pain, or had they not. So he got all their answers, and then he was able to go in and this is before imaging, before MRIs and all those types of things. And then he was able to go and examine their shoulders after they had died. And what he found was that a large number of people over the age of 60 or 65 had rotator cuff tears and didn't even know it. So people who had never had shoulder pain in their life, actually had defects in these tendons. And you'd think to yourself, well, why is that the case? I mean, number one, wouldn't they know it? And number two, how did it happen? So I guess the answer to the second question is we don't exactly know how it happened. I mean, we know that the tissues do get less elastic over time. It would what we would call an attritional type tear, so that just developed a tear because it just wasn't functioning the same way and the tendon quality was not as good. But again, what's more confusing is how come they didn't know, you know? And so it speaks to the fact that just because you have a tear doesn't necessarily mean that, number one, that's the source of your problem. Like the gentleman who came with the frozen shoulder, that wasn't his problem. He never had shoulder pain before he developed this frozen shoulder. So he had a tear there that he didn't know about. So that's a red herring. And if you go biting on that, you could potentially do your patient harm, and you're not getting to the source of the problem. So you have to be real careful. And so I use certain decision-making rules of thumb in terms of how I decide where to slot people for what types of treatment we should do for them. And again, the first one I do is what I've talked about, and hopefully you'll take home, and is that the treatment's individualized based on our conversation, what you want. But the second one is, is this a traumatic tear? Is this a chronic tear? How did this come to be? Where does this fit within the overall health of your shoulder? Because that'll guide me then to this. What are the options? So I didn't cover a lot of things with rotator cuff tears. There's a whole wide number of things I didn't cover. I didn't cover what types of tears there are. So what I can tell you is that there's a huge variation. There's what we call partial tears, which oftentimes I'm convinced that MRIs overcall. So often people will say, oh, well, it looks like you have a rotator cuff tear. And what I can tell you is that a lot of MRIs aren't good enough quality to tell you, a partial tear, and that the normal aging tendon can look like that. So again, be careful about that. Are there people with partial tear? Sure. I just operated on a gentleman the other day who was a baseball player who had a little bit of partial tear. Partial tear, though, there's a wide variety of those too. You can have anything from what I would call fraying, like the end of your pants rubbing against the ground. That can be a partial tear. Or you can have one where it's almost threadbare, where you can almost see through my pants and see my leg. So there's a big variation, and how I would treat those is variable. So all those things factor into which of these solutions we're going to talk about. Some people already come to me thinking, I have a tear, I need surgery. And they may be scared, or it may prevent them from coming in because they're afraid that, oh, you told me I have a tear, I must have to go to the operating room. My brother-in-law had that. Not necessarily the case, right? Partial thickness rotator cuff tears or chronic small tears, you can often wait on those. You can often try a number of other things like this stuff, the same types of treatments that we used for adhesive capsulitis before you ever get to here, which is the operating room. Now, just so you know, I'm oversimplifying a bit, but just so you know, there's definitely differences in what I would do for a person with a rotator cuff tear in physical therapy versus someone with adhesive capsulitis. Okay, so their therapy regimen is going to be different. So it is slightly more complicated, but ultimately it does boil down to some basic broad categories of treatments. and they fall into the more conservative, which are injections, anti-inflammatories judiciously, and physical therapy tailored to what your specific problem is, and surgeries. There's a number of different types of ways of doing surgery on the rotator cuff. I was trained in both major categories, and they basically break down to open surgery, so larger incisions, and arthroscopic. I have to say the majority of my rotator cuffs, greater than 90%, 95% probably at this point, are arthroscopic, and it's probably what a lot of people have heard about. And in a nutshell, it's basically making small incisions, about a centimeter in length or so, and using instruments like if I have it, essentially this size, like a pen or a pencil. So one of those instruments will be a camera. You'll see that here. We call it the Arthroscope, and it's got a fiber optic camera on it attached to it. It'll show up on a monitor. You'll see the picture in 3D. And then the other instruments are various tools. We have a whole assortment of different tools. I liken it a little bit to building a ship in a bottle. So instead of having to open up the shoulder all the way to sew things back together, we use instruments that, as you can see, have sort of long handles and that do the same thing that I'd be doing in a open situation, but in a very specialized way. So it takes special training to do that. Obviously, it takes a lot of practice, but it's something that, you know, when I'm lucky enough to have trained in a time where it was actually a very regular part of our training program, and I also did further training, did a whole year doing nothing but shoulder and elbow surgery with a large number of cases dedicated to arthroscopic surgery specifically. Again, does this mean that every rotator cuff is amenable to that? So say you failed this stuff. Say we decided, well, this is the stuff that's right for you, the non-operative treatment. You're ready to go to a surgery. Is everyone amenable to that? No, not necessarily. Okay. There's actually, once we even get to this point where we're talking surgery, sometimes you have a rotator cuff tear that's not fixable. Okay. Sometimes it's just you're dealing with tissue that's either been just poor quality, the tendon tear may be too old, and it's not necessarily going to get you a good result, because ultimately, in order for it to work, you've got to get some form of healing of this tissue back to the bone. Otherwise, it doesn't do what you wanted it to do. So there's a wide spectrum to even what I didn't mention here, but to even some types of shoulder replacements which work in lieu of the rotator cuff. So, and we can talk more specifically. You can ask questions later. I'm not going to I don't want to delve too deeply, but again, just to the point of there's often more than one type of solution, and it really takes a discussion between you and me to figure out where you fit. Are you someone who was a trauma, who I think has a better chance of doing well in the long run if we fix it quickly? Or are you someone who we can wait on and see and watch and wait because we know that tendon tears get bigger, but we have some time to work with it? You know, are you one of those people? And where is your tendon tear? Is that affecting our decision making? And all those things I can only know based on, you know, talking to you individually. Our last grouping is arthritis. So this is probably this is another one that provides a lot of confusion in the shoulder, because knee and hip arthritis are extraordinarily common. And I don't know if anyone in the audience saw my other talk. I gave another talk here, and I think they put it up online. But I talked specifically about arthritis the entire talk. So if you want a more in-depth view of arthritis, you can go online on our website, and we talked about arthritis. So I mentioned in there, though, that it's confusing because arthritis is, in our minds, thought to be a wear and tear phenomenon. And in some cases it is, right? So as we age, it just makes sense. Well, we walked many miles in these shoes, and therefore my joint's wearing out, and I'm old, and, must be arthritis in the shoulder. But it turns out that shoulder arthritis is different. Shoulder arthritis, first of all, there's more than one joint in the shoulder. There's actually 3 or 4 if you look at it closely. In this picture, I've only highlighted 2 of them, which is these are the most common joints in the shoulder that get arthritis. So for all intents and purposes, that's what we'll be speaking about. So that's number 1. But number 2, shoulder arthritis, at least this type with the ball and socket joint, the glenohumeral joint, as we call it, is often not a wear and tear phenomenon. Often there's some genetic component to it that we don't yet totally understand. We know that there's a whole host of thousands of different genes that get turned on and off that create cartilage. And if anyone in the process of your lifetime over the course of 80 years or so has an issue, you can get arthritis more quickly, which is why I see a lot of patients who get this type of arthritis, but they get it on both shoulders. So, and I see people who've never done anything athletic and never done any hard labor who look like this. In fact, the case I did last week was an example just like that. So that's one of the differences. The other one is that the arthritis really is different in these two joints. So the arthritis up here in the what we call AC joint, so this is your acromion and this is your clavicle, so the fancy words for collarbone and shoulder blade, where those two meet right there, it's actually very common to get that type of arthritis. But that's a case where it is often associated with people who do heavy work, so people who weight lift, laborers, lift stuff heavy their whole life. That's actually pretty common. One of the interesting things, though, is sort of like rotator cuff tears, there's a lot of people walking around with this arthritis that don't even know it. So I guarantee you if I x-rayed everybody in this audience, we'd have a lot of people with this type of arthritis, but most people, it never would have really bugged them, or maybe it did for a little while and it burned itself out. So the good news about this type is that it often gets better just on its own. And that's another one sort of like a frozen shoulder, where if you have it, maybe just wait. Maybe just wait and see and wait it out. If you can wait it out, maybe it just gets better on its own. Or maybe you try one of these treatments like an injection and it burns itself out. Maybe it won't. But the bottom line is you really don't want to get stuck in the trap where you go in, the doctor looks at your x-ray, says, oh, you've got arthritis there, go to a surgeon, and them say right away, without giving you some time, or at least talking it over and figuring it out, say you need to go to the operating room right away. Now, are there cases where you can do that? Sure, and that gets back to, again, making a decision based on your own preferences. So there's a trade-off. There's people who, for instance, I had a truck driver who had to be lifting heavy freight. He had waited long enough, at least in his mind. I mean, it was less than a year, but he waited long enough in his mind. He just wanted an operation. He just wanted it done. Did the operation, got better. Okay, great. But there's a lot of other people who don't need to have it done that quickly. I mean, maybe they can wait it out. Maybe their job's a desk job and they can give it more time or they can have more patience with it. But again, it's variable. I mean, he needed it done quickly, someone else doesn't. But just be careful. This type of arthritis in the glenohumeral joint, different, right? So here you're dealing with a different situation. This is the type of arthritis that my doctor patient, who I just saw today, who I injected, this is the type of arthritis he had, or he has. His x-ray looks a lot like this. And what I'm circling here is the joint, but what you see down here, this is actually abnormal. This part here is abnormal. We call it a goat's beard, and you can see why. It looks like a little beard of a little goat. That's all abnormal. What that is a bone spur. So we hear that term a lot, bone spurs. Doctor says I have bone spurs. What do I do? This bone spur, a pathology professor of mine once said, bone has one trick. Bone has one trick. That trick is to make more bone. So like a callus on your hand grows in reaction to some kind of stress, that's what these do. These grow in reaction to stress. The reason why you have stress is because you've worn away this super smooth layer of cartilage for whatever reason. Forget the reason. It doesn't matter at this point. You've worn it away. And once you wear that away, these surfaces start to stress. And the bone reacts by saying, hey, stop moving. This hurts. And ultimately, the body's objective is to lock you up and to stop you from moving. In fact, I've operated on a few folks who, I had one gentleman who I don't know how he lasted so long. He was a farmer, and I guess he just had a tremendously high pain tolerance. But he was so locked up, I could barely get his shoulder out of joint, which you have to do. I don't want to gross anybody out here, but it's what you have to do when you replace a shoulder. But he had so much of this bone spur here, it literally was locking up his joint. I mean, he just couldn't move, could barely move. So that's an extreme example. So what are your options? Well, the options depend really on a number of things, like everything else, a number of things, a whole cadre of different things. Number one, on the two different types of arthritis. So let's jump to surgery. We'll backtrack a little bit to the non-surgical options. We'll jump to the surgical options. say you're dealing with the AC joint, which is where the collarbone meets the shoulder blade, versus the glenohumeral joint, the ball and socket, the surgeries are vastly different. The surgeries are vastly different. So for the AC joint, literally all you have to do is shave away a little width of bone, about the width of my pinky. It's actually a relatively straightforward procedure, outpatient procedure, can be done arthroscopically. Arthritis of the glenohumeral joint, that ball and socket, ultimately, you may be looking at joint replacement. Now I say ultimately because there's a wide spectrum of people. I've only had one of these guys, but I had one gentleman who was in his 80s who, again, he wanted an operation. I recommended a shoulder replacement. Didn't want anything to do with a shoulder replacement. He knew what he wanted. He wanted a scope, an arthroscopy, a small, minimally invasive surgery. And I did that for him. I did it because there was very little downside, even though I thought and knew that he probably wouldn't get too much better. Now, according to him, he got better. He's probably the only one I've seen like that who actually got better with that. But most people, when you're older especially. Now, if it's a younger patient, this is where it gets to, more than one good treatment option. If you're younger and you have this x-ray right there, if you're, say, 40 as opposed to 70 or 65 and have this, then I'm going to hesitate with offering you a shoulder replacement. Are there people who've done them? Sure. But we're going to hesitate because you're so young. And we want you, if we actually go to this, we want you to try and outlive this. Because like anything else, these implants have the life of their own. And they wear and the components wear. And so, again, decision making is different based on who you are, which I can't know unless I know you. So backtrack a little bit. We'll talk about the lesser options, the more conservative options. So I put in, you'll notice one conspicuously absent. I didn't put the physical therapy option in with arthritis. And the reason for that is, in my practice, this is something that I've just seen in my own clinical practice, but in my practice what I found is that people with arthritis that's as bad as this here tend to be more annoyed by physical therapy than anything, because once you get to that point, usually you're feeling crunching and popping and bone on bone, and me getting you to move more just makes it feel more like sandpaper and just hurts. Can it help? Sure. I mean, you can, because ultimately it's not just about that bone on bone. What you have is a tightening down of the capsule tissue like you have in the frozen shoulder, and that hurts. So sometimes just stretching that out can help people. But there's very few people, I think, who can tolerate it. I've had a few patients who were professionals. One was a yoga instructor and another one who is a painter, who ultimately, because of their jobs, had to do a lot of stretching and had fantastic motion with terrible x-rays. But I think those people are the exception rather than the rule. So for the most part in my practice, I really try not to torture people with physical therapy for end-stage osteoarthritis, because you often end up getting some temporary gain, but end up in the same boat, and it may be more painful to you in the long run. So ultimately, I usually stick for conservative treatments more with these types of options. And my gentleman, my doctor patient, is a perfect example of that. He's a guy who, for all intents and purposes, would benefit from this, from a shoulder replacement, but doesn't want one. He's 78 years old, he plays tennis, he does push-ups every day, and he can live with a certain amount of pain. So how do I know how much pain you can live with versus how much pain you can live with? I don't know that answer. I mean, only you know that answer. And the general rule should be, don't go for one of these unless you're having more bad days than good and you don't have any other good option. You feel like, okay, I've got to really do something and I can't take it anymore. Because sometimes you can just work with these types of things. Now, are there downsides to injections? Sure. And the downsides to injections, pills such as anti-inflammatories, sometimes they interact with your hypertension medications. Injections, you give too many and they can actually wear your rotator cuff. They can degenerate your rotator cuff. So you got to be careful about that too. So there's no free lunch, unfortunately, with anything we do. I mean, everything is a balance of costs and benefits, and you have to think about what works for you. So can you get injections indefinitely? Maybe, but often what you find is they work well in the beginning, and then over time they may or may not. So they're not a cure, they're a Band-Aid, but it's a Band-Aid that sometimes works for a long enough time to buy you time. So In conclusion, it comes down to making good choices, right? And it turns out that there's a lot of options which can be confusing, but ultimately can be simplified too, based on what your own priorities are and what the costs and benefits are to you. Because ultimately, one treatment has a different value to person X than person Y, and that's just based on your own specific circumstances. Hopefully, if you find the right person, they can help guide you through some of those decisions, because it is complicated, and you are not your brother-in-law or sister-in-law, and you know, one solution that's right for them may not be right for you. So what I want to do now is, if you've written down any questions, I want to open it up to questions, and hopefully you found it enlightening. Yes?
On the rotator cuff tear, are there some tears where the tendon will actually repair normally, and if so, will the weaker shoulder resolve, or can you get accident resolved?
So that's a good question. Yeah, that's a good question. What she's asking is, with rotator cuff tears, will they ultimately repair themselves? Can some repair themselves, and or not? And so there's a wide spectrum of rotator cuff tears, from what we call partial tears to full thickness tears. Now the partial tears, sometimes they just get inflamed, and that fraying that you might see, it's really just the inflammation that's bothering you. And if your body, for whatever reason, gets rid of that inflammation, or if through some help with an injection you get rid of that, or through strengthening around it you get rid of it, you can live with it that way. Will the fraying necessarily go away? Usually it doesn't. Usually it doesn't just automatically repair itself. Will a tendon tear like this, that's actually fully torn from the bone, where you can see it torn right from the bone, will that repair itself? The answer is no. And the reason for that is because the muscles act like springs. So the muscle's main job is to get shorter, to contract. When you've released this tension, it pulls the tendon back, and when it does that, it keeps, the tendon has to live here. It has to, in order to do its job, it's got to live right there. It's got to live right there. If the muscle spring pulls back, it's being held from reattaching where it wants to. It's not like other tissues where there's less tension on it. And so that's one of the important reasons why, if you're continuing to have pain and you have a full tear, the only way to really restore that strength and restore its normal anatomic location is for someone to put it back there. And you do that with surgery. So the question is, with chronic rotator cuff tears, so I made a distinction between acute or traumatic and chronic rotator cuff tears. And the answer is yes. Or what he's saying is there something in the tendon? Is there a deterioration in the tendon that is happening that's causing a rotator cuff tear to happen? And then if that happens, will it just continue to get worse? And so the answer is yes, there is a deterioration in the tendon. So in general, tendons age just like the rest of our bodies age. So just as our skin changes over time and we notice we get wrinkles and all this stuff, the tendons age to a degree. So they and a lot of it's a little too sophisticated for a talk like this to get into, cellular changes. But there is a change going on that makes them ultimately less elastic, less resilient to forces, and a certain amount of degeneration, so a certain amount of loss of strength, and sometimes infiltration of fatty tissue. So when a tear arises, what you have to know is that they can get bigger, and when they happen chronically, they tend to get bigger over time. So if you start with a small one and you come back in 5 years, you're probably going to have a bigger tear. If your tear started at 1 centimeter, ultimately it probably will get bigger. And the reason that's important is because then I can counsel you in terms of, well, this one's chronic. I mean, this one, I didn't fall off a roof or anything, but I know that slowly it's gotten worse, and I've got an MRI here showing it to me. Doc, when do I get this taken care of? When should I have it done and where, I'm still safe in getting it repaired and it doesn't get to be a point where it's not repairable anymore? Because certainly that can happen too. I mean, I've encountered patients who eventually they come to you and it's so bad or so big or so degenerative that then you can't repair it. The tissue becomes, just has much less healing capacity. This is a problem a lot with smokers or diabetics. And the reason for that is, like anything else, smoking constricts blood vessels, and it deteriorates the blood supply to the tissue. So often what you're looking at is how good is the blood supply, what is the healing potential of the tissue, and that depends on the particular patient. So a good rule of thumb is if you know you have a tear and it's relatively small, to keep an eye on it. You know, do you have to get a new scan every year? No, but you may not want to let it get out of hand because at some point it may get to a point where it's irreparable. Can I predict when exactly? Not exactly. We've got some studies that can guide us, and we know it's usually more a matter of years as opposed to weeks. So if you came in and you have a tear one day, it's not usually, unless you have another trauma, not tomorrow going to blow up and be irreparable if today it was just a small tear. But the process does happen, and they do get worse, and there may come a point where it isn't fixable. And the only way to know that is by looking at it. Sometimes that's when you need the advanced MRIs to actually get a look and look at the quality of the tissue. Oh, sure, all the way in the back, yeah.
Yeah, mine more on diagnosis. Did your experience allow you to make that, you said you could tell face to face without the MRI, or narrow it down anyway, between rotator cuff or frozen shoulder or arthritis now?
Between those three diagnoses specifically is what you're asking? Between those three usually, and the reason is because frozen shoulder and arthritis both present with stiffness. So his question was, can you tell the difference between the three diagnoses I presented without an MRI? Usually you can, and the reason is because frozen shoulder and arthritis are the two most common diagnoses where you have stiffness. The way I distinguish then between the two of frozen shoulder and arthritis is I get an x-ray. X-ray shows me arthritis. I don't need an MRI for arthritis. And that's why if you come to me, if your doctor thinks you have arthritis and is ordering you an MRI, it's the wrong test. Unless they're going to do surgery or something and are looking for the arthritis and the rotator cuff tear. MRI demonstrates soft tissues, tendons, muscles, better than anything else. So there is a place for an MRI sometimes, but in order to purely make the diagnosis, if you come to me as a blank slate and I want to know the difference, I don't need an MRI to tell you the difference between arthritis, frozen shoulder, and rotator cuff tear. Now, if you are really stiff and have a rotator cuff tear, can I necessarily tell that you have one or don't have one? No. Without an MRI, no. I may need an MRI. But in that case, for me, it doesn't really matter that much because if you come to me first stiff, then the stiffness to me trumps your tear. And so I'm not going to worry about treating your rotator cuff tear that much because I'm going to worry about getting your motion back first before ever considering something like a surgery because I have the potential to make you worse if I treat your cuff tear first. Does everybody understand that? It's a subtle point, but it actually makes a big difference. So if you have a cuff tear, you can have a cuff tear and be loose, or have a cuff tear and have normal motion, have a cuff tear and be stiff, but they're two different problems. And it doesn't really behoove me to get an MRI if you're coming to me with stiffness first because that stiffness problem, it's like saying, well, the carpet downstairs is dirty, I've got a vacuum, but the roof is caving in upstairs, because it's pouring rain. Am I going to start vacuuming first? No, because ultimately the roof may cave in and, I've got to treat that first and then later on I can possibly treat the rotator cuff tear. So I don't know who to go to first, but there's a hand here. Go ahead.
On the steroid injections, can that damage the tendon? I mean, is there a risk there to doing that? Or?
That's another really good question. The question was, can steroids damage the tendon? So what you'll often hear is a rule of 3, and a lot of doctors will tell you you're not allowed to have more than 3 injections per year. And that there's some truth to that. The number itself is really not definitively known. In other words, there's no studies out there saying, oh yeah, 4 is where it all goes to heck, and 2 is okay, and 3 is just right. It's not like that. So it's really just sort of a general number, and the reason is it probably has something to do with how long the medication sticks around, and sometimes the medication can stick around for about 4 to 6 weeks. But yes, it can ultimately, if you give too many injections, which is why I tend not to just keep throwing injections at people, except in rare circumstances, it can degenerate your rotator cuff to a degree, so you can get some fatty infiltration in the rotator cuff. It can make it weaker. You'll notice that there's a certain group of patients, namely rheumatoid arthritis or other patients who have to be on chronic oral steroids, people who have COPD. and you'll notice that their skin is poor, and sometimes they have bad connective tissue problems. It's for that reason. It's because ultimately you can kind of break it down. So yeah, you have to be very judicious. And that's why usually my rule of thumb is if we're hitting a point where we've done a couple, still not going anywhere, well, let's take the next step and let's look further. Let's consider something else. Now, are there people who I will do chronic injections for? Sure. And the gentleman I saw this morning is a good example. He gets one every couple months. He's avoiding a shoulder replacement. That's fine. We'll do it for a while. But I'm not injecting near his rotator cuff. I'm trying to inject more into his joint. There's other people who maybe get to a point where the rotator cuff is not repairable, right? So maybe we've either tried, or it's just the rotator cuff is their tear is so big or degenerative that you can't actually repair it. Those people, I don't mind giving chronic injections to, as long as their other health is doesn't pose any conflict with it. And that's because if your cuff is already torn and gone, then I'm not really going to do much. I can't do damage to you if it's already. So anyway, but that's a really, really good question. All the way in the back in the white.
What about Sarah?
Oh, I'm sorry. Which? No, go ahead. I'm sorry.
What about Seraphin injections?
I'm not familiar with that. I don't know.
It's chicken.
Oh, Synvisc. Yeah, that's a whole different. It's actually evolving, and at our recent American Academy of Orthopaedics meeting in the springtime, there's actually been less enthusiasm about that. First of all, it's not FDA approved in the shoulder. It's approved more for the knee and hip. I've personally never been a huge fan of it, because I feel like the benefit is somewhat marginal, because what you have to understand about arthritis is that it ultimately, you have good days and bad days, and it sort of gets worse over time, but it goes in this type of pattern. So how do you know that I did an injection when you were really bad, and then maybe you were just heading down on the curve and you got better, but you relate it to, oh, the injection did it. But then there's plenty of other people where it didn't help them. They say, oh, those injections are garbage. So I personally don't use them in the shoulder, and I've used them before in the knee, but I'm much less enthusiastic. I just don't think, let's put it this way. I think if you had to pay out of pocket for them, you probably wouldn't. If you had to, the benefit is very marginal. Most of the studies were funded by the companies that put the stuff out, and they're very expensive, and I just am not a huge fan of them. I don't think they give you a tremendous benefit overall. So, all the way in the back in the white there, sorry.
I think I have a Ruth Carter question for you.
Yeah, okay.
I'm pretty sure I have a cuff tear that was all baseball about 30, 40 years ago. But in recent years, I've had night numbness in my arms that I think is caused by a pinched nerve in my neck. So what's more important? How do I know the difference? Does one doctor do it all?
Yeah, I can help diagnose those types of things. Ultimately, if you needed to be treated for a pinched nerve in your neck, there is a lot of crossover. His question is, what's more important? Say I have a pinched nerve in my neck and a shoulder problem, and how do you distinguish? So ultimately, there's a lot of crossover between the two, because all the nerves from your neck go down through essentially like a cable of nerves into your arm. We call the brachial plexus. So they supply your arm. And so it's important to kind of be able to distinguish between those. So we do subspecialize to a degree where if we got to a point where, say, your neck needed some treatment, we would usually refer you to a neck specialist. But it is important to be able to try and distinguish. And sometimes you can't distinguish between the two. And it'll depend on what we'd have to do for you. Let's say, for instance, we had to do a shoulder surgery, then I'm going to try and decide between me and the person that we had you see for your neck, which one might be more important between us, because there's different degrees of neck problems too. I mean, there's neck problems where you have spinal cord compression, and I'd be really worried if we put you in an awkward position on an operating table, and then there's ones that really are much lower degree, and it would just be variable depending on your specific circumstance. It's not as black and white as the frozen shoulder rotator cuff issue. It's not like that.
I'm glad that he said what he did. I've been having the same thing with my arm, and I'm like, what in the world? So I have an X-ray. I got a teeny tiny bit of arthritis, and I'm like, no, there's something else going on, because I'm getting this numbness shooting down my arms and my fingers now. So we have an MRI. It's my C6.
Yeah.
Okay, and C6 runs across and shoots all this stuff down both arms. Where does those nerves come in? Are they more central and into, or are they on top of, or where are they?
Yeah, I mean, this diagram is really with a lot of layers removed. But I can tell you that the brachial plexus, which is the cable of multiple nerves, kind of runs down in this general area, and then a number of nerves kind of split off in different directions and run down here. But what you're talking about, if you know for certain that it's C6, so your vertebrae are, yeah, I mean, if we're using that example, the vertebrae in your neck are essentially like segments, layers, and so you can get a pinch in there. The pinch would be at the neck if it's what you're describing. I mean, I don't know, I haven't looked at your particular case, but if it is, it's up there, and that has a certain distribution throughout your arm that is unique to that particular nerve root. So.
Going back to the rotator cuff tear, but if you were diagnosed with one and you are trying to do pain, physical surgery or whatever treatment, and you get a lot of bone and popping and grinding noises, I'm worried about the stability of your shoulder in certain tear situations. If you have other kinds of problems while you're waiting and getting your cuff repaired, does it affect stability or?
So the question is, if you already know that you're going to have surgery, I want to see if I'm getting you right. You already know you're going to have surgery, and in the interim, you still feel popping, you're concerned about stability. Can you do more damage? Is that the question?
And there's been a lot of muscle atrophy because you're trying to rest up,
Right.
up and behave, you know?
The muscle atrophy you may or may not be able to do anything about because, muscles atrophy when you don't use them, and often you can't use them because you're in pain, and it's sort of a vicious cycle. Can you do more damage? Sure, but it just depends on how extensive your activity level is. So if you're being relatively sedate, probably not. But it just really depends on the particular problem. It's impossible to know without knowing the particular circumstance. There's some people who I could tell you, here's what you should do, what you shouldn't do. But once you're usually in the pipeline, waiting for something, you're on your way. They're not going to, if they knew that, if it was more urgent, let's put it this way, if it was more urgent, they'd do it quickly. So, and I will counsel people. Some people I'll tell them, you probably should get a surgery within X number of months, or no, you can wait on this. It just depends on the character of the injury.